Buongiorno, anzi buon pomeriggio. Continua la giornata del nostro appuntamento importante del 26 di novembre 2020. Ricerca e confronti. Ricerca e confronti porta per la prima volta un importante incontro dei maggiori esperti italiani e stranieri, europei, in una tavola senza precedenti. Il mio benvenuto in italiano a tutti coloro che ci ascoltano dall'Italia, ma per presentare il nostro importante ospite che vedete già nella finestra in alto, lascio la parola a Giulia Volpato, la nostra vicepresidente. Giulia.
Welcome, Dr. Eric Garbison from France. Dr. Garbison works in the Paris hospital like corneal surgery. So, Eric, you can start your presentation. Thank you.
Thank you very much. Thank you for the invitation. And I'm very happy to be here with you today to present you some of the features, pathophysiology, and the management of E.E.C. associated keratopathy. I have a PowerPoint slide. How to?
You must share.
Okay, share the screen.
Okay, we can see your screen.
Can you see? Okay.
Yes, we can see.
So I'm going to present you some of the pathophysiology and management of E.E.C. syndrome associated keratopathy. In order to understand, I'm going to present you the cornea, and the cornea is the first diopter of the eye. And in order to maintain vision, it has to stay transparent and regular in shape. One of the main actors of corneal transparency is the corneal epithelium. Corneal epithelial stem cells are located at the corneal periphery between the cornea and conjunctiva in a specialized area that is called the Vogt palisade. Corneal epithelial turnover is associated with centripetal migration and maturation of epithelial cells. Lambert stem cell niche is located at the corneal periphery, and transient amplifying cells, post-mitotic cells, and totally differentiated cells migrate toward the central cornea. Here you can see immature cells and the apparition of cornea-specific markers of differentiation K3 and K12 in superficial cells. This is a cross-section of a Lambert stem cell niche in which you can see P63 bright cells, stained cells in basal epithelial cells here. And you can see mature involucrine positive cells in the superficial layers. One thing that is very important in the cornea is that in order to maintain corneal homeostasis and corneal transparency, several actors are mandatory. This includes tears that contain growth factors directed toward the corneal epithelium as a trophic factor. Additionally, epithelial cells and corneal nerves produce growth factors and neurotrophic factors that are targeting the corneal stroma. In response, the stroma is producing growth factor and trophic factor targeting the epithelium as a crosstalk of nutrition, cross-nutrition. So in order to stop this, to finish this slide, I wanted to say that you cannot have healthy epithelium without healthy stroma, and vice versa. You cannot have healthy stroma without healthy epithelium. Lambert stem cell deficiency is a progressive disorder that may be acquired or genetically inherited. It may progressively lead to corneal opacification due to loss of transparency of the epithelium, loss of transparency of the stroma, and associated corneal neovascularization. In this slide, you can see loss of corneal epithelial transparency due to progressive conjunctivalization of the peripheral cornea. So you can see that several different, different clinical aspects may be encountered in Lambert stem cell deficiency. It can be partial without neovascularization, partial with neovascularization, total with without neovascularization, total with neovascularization, total with neovascularization and stromal fibrosis, and in the more severe cases, you have total with ulceration and neovascularization. So as a conclusion of this slide, we can say that an isolated epithelial disorder may lead to a total epithelial and stromal disorder with total loss of transparency. In the presence of defective healing, corneal ulceration may lead to thinning and ultimately fibrosis in case of healing, and in the worst cases may lead to corneal perforation. P63 related keratopathy pathophysiology is linked with a vicious cycle leading to the loss of corneal transparency. You have epithelial instability that will lead to persistent epithelial defect. The defective meibomian gland is increasing dry eyes and increasing in the same time epithelial instability. Defective healing may lead to stem cell niche depletion and worsening of limbal stem cell deficiency. Healing will be associated with fibrosis that will induce loss of transparency associated with conjunctivalization. So you can see that this is a very vicious circle that needs to be targeted in the management of such patients. In order to prevent worsening of P63-associated keratopathy and block the vicious circle, autologous steroid is one of the main actors in this management. It decreases corneal inflammation, improves healing of epithelial cells, and prevents corneal ulceration. We use it usually when clinical signs of epithelial fragility is present, or if the patient has a past history of corneal ulceration and persistent epithelial defects. Another great actor in the management of the P63-associated, E.E.C.-associated keratopathy is the scleral contact lens. It is a very wide and large contact lens that does not touch the cornea. It protects the cornea, is totally filled of saline, and it protects the cornea from injuries. It is associated, it treats also severe dry eyes, and it improves vision. Of course, it cannot improve the transparency in the beginning, but it improves the regularity of the cornea, improve vision. And by decreasing the risk of corneal ulceration, it helps the prevention of fibrosis. Another main actor of the management of E.E.C.-associated keratopathy is amniotic membrane. It can be used in overlay, meaning as a dressing on top of the cornea, or in cases of ulceration and perforation. It can be sutured in the thinned area of the cornea. Keratoplasty now. One thing that is very important in keratoplasty is that it does not correct stem cell deficiency. The keratoplasty only replaces the 8 mm central part of the cornea, and it does not add any epithelial stem cells. So it is usually associated with defective healing, ulceration, perforation, and recurrence of conjunctivalization, as you can see here. Keratoprosthesis is another tool that we can use in the management of E.E.C.-associated keratopathy. However, it is an artificial cornea that is placed in the central part of the corneal graft, as you can see here, and that is secondarily sutured to the patient cornea. But such device is associated with stromal males, glaucoma, and fibrosis of the anterior segment. So it is only used in the very last stages of the disease. I wanted to show you some clinical cases that are coming from mild cases than the more severe older cases. Father and son, 33-year-old male, with bilateral stem cell deficiency, only 50% of limbal stem cell deficiency. Vision is good due to scleral contact lens. And his son is 3-year-old boy with dry eye, superficial keratitis and 25% of limbal stem cell deficiency. No ulceration in both cases. Another case is a 37-year-old monophthalmus due to the loss of the right eye due to keratoplasty that was performed more than 30 years ago. The loss of the eye was due to healing defect and rejection with total conjunctivalization. The other eye was adapted with scleral lenses, and you can see limbal stem cell deficiency of nearly 50% of the limbal area. The fourth case is a 50-year-old monophthalmus also due to the loss of the right eye due to keratoprosthesis that was performed in the 80s, and failure after 6 years of, due to total conjunctivalization and endophthalmitis. Limbal stem cell deficiency is total, and this patient has recurrent erosion, ulceration, and it was managed with autologous serum, scleral contact lens, and repeated amniotic membrane grafts. This is the case of a 52-year-old patient with 360-degree bilateral limbal stem cell deficiency that is not so important. This patient started to go to the cornea clinic due to corneal ulceration. And what is very important, as you can see here in the right eye, is that total loss of transparency and increased stem cell deficiency, particularly in the area where the corneal ulceration was present. So it is very important to emphasize on the fact that each time you have a persistent epithelial defect, each time you have corneal ulceration, the healing will lead to corneal opacification and to the increased worsening of the limbal stem cell. This is the most severe case that we have. It's a 60-year-old monophthalmus patient that was treated with the past history of this patient is the loss of right eye due to corneal keratoplasty more than 30 years ago. And he went to our clinic due to corneal recurrent erosion and severe stem cell deficiency. We treated him with amniotic membrane graft. He had desmatocells and corneal perforation. And ultimately, we treated him with Boston keratoprosthesis, autologous serum, and amniotic membrane graft. And here you can see the different aspects with time of this patient. And we were happy at this stage with the Boston keratoprosthesis. However, we had defective healing and melt of the peripheral part of the Boston keratoprosthesis. Then fungal infection that was treated systemically and topically, and we performed more than 40 surgeries in order to maintain a vision to these patients. Ultimately, we have to say that the gold standard of bilateral stem cell deficiency should be cell therapy and epithelial stem cell treatment. However, in the cases of E.E.C. patients, genetic modulation should be added to be able to maintain and culture these cells. Several options are under investigation. These include pharmacological investigations such as the use of PRIMA, that is a molecule that was initially designed to target p53, but as p53 and p63 are the DNA binding domain are very similar. There are publications showing that it may improve the differentiation toward cornea of corneal epithelial stem cell. Italian group and European group are also investigating the silencing P63 silencing of the mutated P63 using silencing RNA, and they have shown improvement of the culture of P63 epithelial cells from patients. If we look at the literature, there are less than 50 cases of E.E.C. patients that are published, and all these publications are confirming that the keratoplasty is not the gold standard of the management of this patient, with a lot of complication in the follow-up of this patient. If we want to summarize, the best keratoplasty is the one that is not performed, and we need to keep a medical management that includes the treatment of dry eye, autolocous serum, and scleral lenses, and in the cases, in the more severe cases, amniotic membrane graft and keratoplasty and keratoprothesis only in the cases of perforation. And thank you for your attention. I will be happy to answer questions.
Thank you, Dr. Gabizon. Please stop the sharing of the screen, please.
Yeah.
We are receiving so much questions for you, so we have choose 3 of those, and for the others.
Did I stop the
yes,
sharing?
please. I think okay. No, you haven't.
Yes.
Okay. Right. So we have we have choose 3 questions during your presentation, and Roberta is going to read it.
Yes. The first question: what are the symptoms that can warn the patient of the beginning of corneal degeneration?
So this is a very important question. I try to show that the cornea of E.E.C. patient is very fragile. So in any cases, any symptoms that are unusual, that may be red eye, that may be fluctuation of visual acuity, pain, tearing, any signs that is not common should urge the patient to go to the ophthalmologist. The eye of E.E.C. patient is very fragile, so they need to come, even if it's for nothing, they need to come.
Thank you.
Another question: what are the basic pharmacological treatments in patients with E.E.C. syndrome?
Yeah, so this is a very important question, but because I realized that in my presentation, I only talk about biological and contact lens that are very important, but in the milder cases, anything that can treat dry eye and prevent abnormal friction between the lid and the cornea and prevent the corneal erosion. I try to show that in this kind of patient, the epithelium is very fragile. There is epithelial instability. So hyaluronic acid is a well-known treatment that is decreasing the friction forces between the lid and the cornea. So it's a very important treatment. Also, ointments such as vitamin A ointment may prevent, particularly at night when we sleep, we have the eye, when we are dreaming, we have a very, very rapid movement of the eyeball below the lid, and ointment at night may prevent abnormal friction during the night. And so it's very important to say that to the patient.
Thank you. And the last question: from what age can scleral lenses be used?
So it's very important. Scleral lens is very important, as I mentioned, because it treats dry eye, it protects the cornea and improve vision. However, it is very difficult to adapt. Most of our cases are adapted with scleral lenses, but of course it's too early if there's no past history of ulceration. It's not mandatory if the epithelium is not fragile. It's not mandatory if the visual acuity of the patient is correct without any problem. So the best patient to be adapted with this lens is patient with epithelial instability, severe dry eye, past history of recurrent erosion, and yes, and a patient that is willing to put this lens, because the training of the patient is important in this in the use of this lens.
I use the
so I didn't answer the age, but usually we did not adapt this lens before the age of 12-year-old.
Okay, well, I use the experiences from 2017, and for me they are really, really helpful. I can't stay without experiences.
It's the gold standard. Yes,
Exactly.
it's very important to let the information going on that.
Thank you for your presentation, Dr. Grevison, and all the other questions we receive an answer in our Facebook webpage and during the next days. Now, so thank you for your participation in our international meeting on E.E.C syndrome and P63 gene. Now we give the word to the next one speaker, that is the dermatology, Dottoressa Irene Russo from the University of Padua.
Good morning, everyone. I'm Irene Russo. I'm a dermatologist, and today I'm speaking on behalf of Professor Anna Belloni Fortina. I'm going to talk to you about P63 related disorders and in particular about E.E.C syndrome. E.E.C syndrome was first described by Eckel and Martens in 1804. Is a very rare genetic disorder and is a rare form of ectodermal dysplasia. E.E.C syndrome is characterized by three main clinical features, which are ectrodactyly, ectodermal dysplasia, and cleft lip and/or palate. What are ectodermal dysplasias? Ectodermal dysplasias are genetic conditions characterized by having abnormalities in two or more of the major ectodermal structures, including the skin, hair, teeth, nails, and sweat glands. To comprehend the pathogenesis of ectodermal dysplasias, it is very important to give you some background information. Here you can see an embryonic process which is called gastrulation. During gastrulation, the blastula, which has only one layer of cells, becomes a gastrula, which has three layers of cells that are called endoderm, mesoderm, and ectoderm. Here you can see again the gastrula with its three primary germ layers. The endoderm, which is the inner layer, gives rise to the gut and many internal organs. The mesoderm gives rise to the muscle cells and the connective tissue of the body. And the ectoderm, which is the most exterior of the three primary germ layers, differentiates into three parts, which are called the surface ectoderm, the neural crest, and the neural tube. So the ectoderm contributes to the development of several structures, and in particular to the development of the skin, the nervous system, both central and peripheral nervous system, and other structures. In particular, there are some structures which derive from the surface ectoderm, which are the epidermis, so the skin, the hair, nails, sebaceous glands, olfactory epithelium, the mouth epithelium and the teeth, and also important ocular structures as lens and cornea. Currently, there are over 180 single gene disorders that are qualified as ectodermal dysplasias. In this recent review, ectodermal dysplasias has been classified and organized by phenotype, genotype, and molecular pathway. Here, in this table, you can see the organization of ectodermal dysplasias based on molecular pathways. And you can see that TP63 pathway is one of the molecular pathways of ectodermal dysplasias. And today we are going to talk about TP63 pathway and in particular about E.E.C syndrome. You can see this is one of the TP63 related disorder. What is P63? P63 is a transcription factor encoded by the gene TP63, which is located on the long arm of chromosome 3. P63 binds certain regions of DNA and controls the activity of particular genes. P63 is very important for the epidermal development. it regulates numerous cell activities, including cell proliferation, maintenance, differentiation, cell adhesions, and also cell apoptosis, and is especially important for the normal development of ectodermal structures such as the skin, hair, teeth, and nails. Mutation in the gene TP63 are responsible of several autosomal dominant disorders. These disorders are called P63-related disorders, and there are 6 main types of P63-related disorders that are called E.E.C syndrome, adult syndrome, E.E.C syndrome, limb mammary syndrome, split hand-foot malformation type 4, and isolated cleft lip, cleft palate. Here, in this table, we can see the clinical features of TP63-related disorders, and you can see that they are clinically overlapping. Today, we are going to talk about E.E.C syndrome. As I told you, there are 3 main clinical features that are ectrodactyly, ectodermal defects, and the cleft palate syndrome. Ectrodactyly is present in approximately 70% of all affected individuals and ranges widely in severity and location of the digital abnormalities. Ectodermal defects are very, very frequent and typically manifest as silvery blonde sparse fine hair, dry skin, nail changes, dental changes, including oligodontian and enamel defects, xerostomia, and subjective decrease in sweating capacity. The cleft lip palate is present in approximately 40% of patients affected by E.E.C. There are also other important clinical manifestations of E.E.C. In particular, ocular alterations are very frequent. They are reported in 90% of individuals affected by E.E.C. The most common ocular alteration is absent lacrimal puncta that sometimes results in tearing, blepharitis, dacryocystitis, keratoconjunctivitis, photophobia, and sometimes lead to corneal ulceration and scarring. And blepharophimosis is seen occasionally too. As I told you, frequently we can observe malformed teeth of conical shape and hypodontia that become evident during childhood and adolescence. Genitourinary malformations are also reported in 45% of patients, so are frequent in these patients. As I told you, P63 is a key regulator of epidermal development, and mutations of P63 alters keratinocytes adhesion, proliferation, differentiation, and also the formation of the basement membrane, inducing an impaired skin barrier. So E.E.C is characterized by many dermatological manifestations that are xerotic skin, palmoplantar hyperkeratosis, hypotrichosis, and nail dystrophy. Xerotic skin is very, very frequent in patients affected by E.E.C. Skin of E.E.C patients tend to be dry, thickened, cracked, and scaly. Itching is very frequent, but erosions are not present. It's important to know that complications of chronic xerotic skin include skin infections and irritant and/or allergic contact dermatitis. What can we do for xerotic skin? We can improve xerotic skin trying to identify and avoid triggers that worsen the dry skin, as aggressive soaps and detergents. It's important to take shorter baths or showers and to use warm water rather than hot water. It's important to use only gentle soaps to dry the skin carefully. And the most important thing is to apply emollients immediately after bathing. Emollients are medical moisturizers which helps skin repair and improves skin hydratations. There are numerous emollients on sale at general stores and pharmacies. So it's important to ask the dermatologist to choose the better emollient. There are lotions which have a high water and low oil content that can worsen xerosis and trigger a flare of the disease. There are also thick creams which have a low water content or ointments which have zero water content that better protect against xerosis, but some patients may complain that they are greasy. And finally, there are emollients containing ceramides that are very, very useful to restore the skin's barrier function. Another dermatological manifestation of E.E.C syndrome is palmoplantar hyperkeratosis, which is very frequent. We can observe thickening of palms and soles, and it's important to improve this condition to use everyday emollients, keratolytic agents, and topical vitamin D ointment. Hypotrichosis could be a very big problem for these patients. Hair changes are very frequent and become more obvious with age and are seen in 60–80% of individuals with E.E.C syndrome. Hair is typically silvery blonde, coarse and dry, and 20% of patients have sparse hair. Eyebrows and eyelashes may be sparse, and also the secondary sexual hair may be affected. So sometimes, in case of sparse hair and alopecia, wigs, if desired, can be used. And the last dermatological manifestation that is very frequent in patients affected by E.E.C is the presence of nail dystrophy. Approximately 80% of E.E.C patients have transverse ridging, pitting, and slow growth of the nail plates. So E.E.C syndrome is a genetic disorder and it is inherited in an autosomal dominant manner. It's very important to know that only 30% of individuals have an affected parent, but the majority of patients affected by E.E.C syndrome, 70% of patients, have a de novo pathogenic variant. So prenatal diagnosis is possible, but only if the pathogenic variant in the family is known. And each child of an individual with E.E.C syndrome has a 50% chance of inheriting the pathogenic variant. It's important also to know that in 90% of patients, the mutation is located in the gene TP63 on chromosome 3, but in 10% of patients, there are abnormalities of chromosome 7. In these very complex disorders, a multidisciplinary team of specialists is recommended and should include specialists in clinical genetics and dermatology, but also in ophthalmology, dentistry, plastic surgery, and so on. I'd like to remind you that AOP, Azienda Ospedaliera Università di Padova, is one of the healthcare providers in Italy for the care of rare disease patients, and that in particular the Unit of Dermatology of University of Padova is a referral center for the diagnosis, the treatment, and the follow-up of patients affected by skin rare disease. I'd like to conclude my presentation giving you our contact information and thanking you for your attention.
So thank you, Dottoressa Russo, for your presentation. I want to remind you that your questions can be sent us by email or by writing them in the comment box below. So, skin and eyes have a common trait. They are the protection of our body. So let's go back to talking about eyes, giving the floor to Dr. Giancarlo Falcicchio, that work on the Carones Eye Center in Milan. Dr. Falcicchio is an expert in clear lenses, specifically on the E.E.C syndrome. So please, Dr. Falcicchio, you have the floor.
Good morning. I'm Giancarlo Falcicchio, an orthoptist and contact lens specialist. At first, I want to thank to Giulia Volpato and all the association of E.E.C syndrome for inviting me to talk about scleral lenses in the management of ocular surface disease. In particular, they asked me to answer to the question if a scleral lens is a prevention tool or a therapy tool. To answer to the question, first we have to understand what is a scleral lens. A scleral lens is a big diameter lens. We go from 15 millimeters up to 25 millimeters that cover entirely the cornea and partially the ocular surface. This kind of lens is made of RGP material with very high gas permeability to offer maximum oxygen amount to the corneal tissues. The lens is not fitted directly on the cornea, but there's a clearance between the lens and the cornea. This space is called liquid reservoir, also called liquid bandage, and it's filled with a preservative-free solution. The edges of the lens lay on scleral conjunctiva, a soft tissue with less sensitivity than the cornea. And because of this, we have an higher level of comfort. Why we use scleral lenses in ocular surface disease? First, because the lens never touches the cornea in any area and in every moment of the day, so we don't have any impact on epithelium or in limbal zone. The lens creates a semi-sealed system, so we can maintain the liquid under the lens even if we have a little tear exchange. So just imagine that the lens works as a suction cup on the eye surface. The lens has no movements on the surface, and this means no mechanical stress and no rubbing on the surface. What are the rules of scleral lens in ocular surface disease management? First, we have protection against dryness, desiccation, and mechanical trauma due to eyelid rubbing, and so recovering of corneal tissues. Second, we have lubrication. It's a constant supply of liquid to the corneal surface. Just imagine it's like to put artificial tears constantly during the day on the surface. Last but not least, we have rehabilitation and improvement of visual acuity. In fact, this kind of lens can mask irregularity of anterior surface of cornea. We know that the normal cornea is perfectly transparent, clearly reflecting, and with no vessel on the surface. In ocular surface disease, because of desiccation, inflammation level, and rubbing of the eyelids on the cornea, we can frequently find conditions as epithelium erosion, ulcers, neovascularization, with the consequent loss of transparency. In all these cases, a scleral lens can assist corneal healing by establishing an ideal habitat that provides continuous hydration without having the interference of mechanical and external forces that may impede epithelium regeneration. Here we have a patient with an ocular surface disease. You can see that the cornea has a neovascularization, a central opacity, and the cornea is no more reflective. The cornea is extremely dry and extremely irregular. This is a picture of the same eye with the scleral lens fitted. And this is the same eye without lens after 3 months of treatment. We can see the difference between the first and the last picture. After 3 months, we can know the difference. We have a reduction of neovascularization, a reduction of the central opacity, and the surface is more reflective and more regular. This is another patient with a corneal ulcer. In this first picture, we can see with fluorescein the presence of an ulcer. This is the same ulcer in slit lamp, and this is the situation before starting scleral lens wearing. This picture is the first follow-up control after 15 days. And this is an OCT scan that shows how after 2 weeks we have an ulcer healing. In ocular surface disease, we usually find a situation of dryness from mild to severe grade due to insufficient presence of tears or altered composition of tear film. This condition can cause different and several symptoms that negatively influence patient quality of life. When we have a normal tear film, this tear film maintains a moist ambient, helps in corneal metabolism, helps in protecting from pathogens, protects cornea and conjunctiva from external irritants. When we have a very dry eye, we find redness and inflammation, stinging or burning sensation, photophobia, itchy eyes, and foreign body sensation. Even in this case, a scleral lens can be very helpful to reduce clinical signs of dry eye and to offer relief from symptoms. But we can't imagine to use a scleral lens without use other medicaments. In fact, scleral lens can cover a part of ocular surface, but not the entire. A portion of conjunctiva will stay dry and will anyway require the use of lubricants. More, the external surface of the scleral lens will benefit from use of artificial tears for maintaining its smoothness and cleaning. So we have the same question here. A scleral lens is a good tool in prevention or only in therapy? Well, I think that scleral lens can be both. In fact, is a good tool in preventing the deterioration of corneal surface and in preventing the reduction of visual acuity. But at the same time, is a good tool in healing corneal tissues and in offering relief from severe dry eye symptoms, and at the same time in recovering visual acuity. So another question we could have: is a scleral lens a efficient treatment? We have to do some consideration about scleral lenses. When we fit the scleral lens, we have to consider that we are anyway reducing the amount of oxygen to corneal tissues. Even if we use the most gas-permeable material, we have to be very careful considering the thickness of the lens and the distance between cornea and lens. More thick and clearance we have, less oxygen will be available for the cornea. Even if we don't have a particular invasiveness on the cornea, a scleral lens is an invasive device on the surface because of its dimension and weight. Designing and fitting a scleral lens in an ocular surface disease require always a good level of experience and knowledge. Every time we fit the square lens, as with every kind of contact lens, we know that we have some risks related to the lens wearing. This is a very important factor when we have eyes with problematic conditions. In conclusion, a square lens is really a life-changing device. Square lens usually is fitted when other medical treatments are not enough and when the patient is starting to have corneal damage and reduction of visual acuity. Square lens is a part of a therapeutic plan, so the ophthalmologist decides when it's the right moment to consider the square lens option. Thanks for your attention. Please contact me if you have any further question. This is my email. Thank you again.
Thank you, Giancarlo. Now the word to Dr. Giovanni Sato, head of the Visual Rehabilitation Center of the Veneto region. Dr. Sato, I know that your presentation will be first in Italian and then translated into English by our staff, right? Okay, so if you are ready, I give you the word.
Parliamo della riabilitazione visiva dell'ipovisione. Sono responsabile del Centro Regionale Veneto per la riabilitazione visiva dell'ipovisione dell'azienda ospedaliera universitaria di Padova, facente parte del Centro Oculistico San Paolo, diretto dal dottor Alessandro Galà. Per ipovisione si intende una disabilità visiva provocata da numerose malattie oculari e neuroftalmologiche. E l'ipovedente presenta un livello di capacità visiva che è insufficiente per svolgere le attività quotidiane di lavoro e di svago che sono invece abituali per individui della stessa età. Quali sono le cause di ipovisione? Sono malattie retiniche come le degenerazioni di tapete retiniche ereditarie centrali e periferiche, che sono malattie rare, il glaucoma, la retinopatia diabetica, le oticopatie, cioè la malattia del nervo ottico, le malattie neuroftalmologiche come esiti di ictus o di tumori cerebrali che portano a emianopsie e quindi deficit del campo visivo destro o sinistro. L'anopsia omonima destra o sinistra o eteronima. Maculopatia senile, che è la causa più importante, più frequente di ipovisione nei paesi occidentali, nella forma atrofica e neovascolare, e anche la maculopatia miopica, nei miopi elevati. Le malattie retiniche colpiscono il centro della retina, la macula, una piccola regione di pochi millimetri di diametro, posta appunto al centro della retina e responsabile della visione centrale, dei dettagli e dei colori. Quindi si ha la presenza di uno scotoma centrale con impossibilità alla lettura e alla visione per lontano. Ma anche malattie di mezzi diottrici, come le malattie corneali, creano un diffuso annebbiamento visivo centrale e periferico, dando luogo a un'ipovisione importante. Quindi l'ipovedente presenta una disabilità visiva perché diventa incapace di leggere, vedere per lontano, guardare la televisione, il teatro, il cinema, nonostante questo periodo appunto dove al cinema non si può andare, lo studio, il lavoro e lo svago. E poi grandi problemi anche di orientamento e mobilità, dato che il paziente non riesce più a muoversi autonomamente da solo nel centro delle città o nelle periferie delle città. E poi quindi insomma tutte le attività di vita quotidiana vengono ad essere interessate, lo sport e così via. Però l'ipovedente è potenzialmente in grado di far uso del residuo visivo, perché l'ipovedente ha un residuo visivo a differenza del cieco assoluto. E questo per la programmazione e l'esecuzione di un certo compito. Quindi dopo un accurato bilancio funzionale viene elaborato un progetto di riabilitazione visiva che porta poi a una riabilitazione del soggetto ipovedente e raggiungere quindi gli obiettivi della riabilitazione, con il recupero delle capacità visive perdute prima della menomazione visiva. Nella maculopatia, come in questo caso, maculopatia dovuta all'età, vengono ad essere utilizzate quelle zone retiniche sane e centriche rispetto alla zona centrale che è atrofizzata, e diventano poi queste quella che si chiama la pseudomacula, pseudofovea o locus retinico preferenziale. Vi sono anche forme di ipovisione periferica dove si cerca di allargare il campo visivo, in particolare con l'utilizzo dei prismi, e poi con una serie di riabilitazioni neurovisive come la stimolazione elettrica transcranica, transoculare, associate a stimolazione neurovisiva. Ora, ovviamente l'ipovedente presenta un grado variabile di depressione perché viene reso isolato rispetto a quello che è la vita di tutti i giorni. Perde il lavoro, viene anche considerato, diciamo, a parte rispetto ai soggetti normali, dato che ci sono anche le categorie protette, però non sono molto protette. E questi pazienti devono cambiare poi lavoro perché, non so, da sarta, infermiera, da perde lo sport, da pallavolista, non può più fare lo sport, da farmacista, webmaster. Una cosa molto frequente, se il soggetto ipovedente va a chiedere a qualcuno che le è vicino o allo stesso guidatore di un bus, ma scusi, che numero è questo autobus? Dice, ma come? Non riesce a leggere. Ecco, viene così come, c'è questa stupore del soggetto normale, come è possibile che qualcuno non possa anche non vedere? Quindi la mancanza di visione è vista come una vergogna, un handicap che non dovrebbe esistere. E sappiamo bene che i giornali scrivono molto molto piccolo e non si preoccupano certo di fare scritte più grandi. Anzi, vi è anche quello che si chiama affollamento delle lettere, per cui il soggetto ipovedente che legge anche col video ingranditore ha difficoltà a leggere anche le parole ingrandite, perché le parole sono proprio attaccate una all'altra. Quindi l'ipovedente dovrebbe essere considerato dal medico, intendo, una persona. Cioè, bisogna trattare il soggetto in tutti gli aspetti, non soltanto oculistico, ma olistico, cioè tutta la persona. Bisogna quindi cercare di portare i pazienti man mano verso un percorso riabilitativo che varia a seconda della malattia che ha causato l'ipovisione, utilizzando degli specifici training percettivo-cognitivi e istruendo il paziente all'uso di ausili ottici o elettronici particolari, sia per lontano che per vicino, in modo da sfruttare quella che abbiamo visto è l'abilità visiva residua, cioè il potenziale visivo. Giulia è una ragazza che è affetta da sindrome E.E.C e questa sindrome crea una opacità della cornea bilaterale con una grave ipovisione. La retina è normale, però la cornea è opaca. E ancora non vi è possibilità con le cellule staminali di modificare queste opacità corneali e di ridare trasparenza alla cornea. Vede un ventesimo, quindi sotto un decimo, quindi è ipovedente grave e presenta una cecità parziale. Vede attraverso una nebbia, non riconosce se è una distanza ravvicinata le cose e le persone. Dopo il percorso riabilitativo si è giunti alla individuazione di determinati ausili che le permettono di poter in un certo qual modo migliorare le sue capacità visive quando utilizza gli ausili. Come in questo caso dove utilizza dei sistemi telescopici da una parte galileiano e dall'altro kepleriano per poter vedere in lontananza stando non camminando, ma stando ferma e individuando il soggetto da vedere lontano oppure anche la televisione. Poi sono stati utilizzati anche dei software ingrandenti che sono molto importanti perché il soggetto ipovedente può riuscire a ingrandire in misura variabile il computer in modo da poter studiare, poter vedere appunto internet e tutti i file. Un altro consiglio molto importante è il videoingranditore da tavolo portatile. In questo caso Giulia sta utilizzando un videoingranditore portatile con il quale vedete che sta utilizzando l'inversione della polarità, sta guardando le lettere bianche su sfondo nero. Si può vedere anche il contrario. Questo perché lei presenta anche un notevole abbagliamento. Un altro sintomo molto importante riferito dai pazienti ipovedenti, cioè l'abbagliamento alle luci sia interne che esterne. Allora, mettendo l'inversione della polarità, è possibile riuscire a leggere meglio. Vedete come questo videoingranditore riesce a ingrandire il testo che sta leggendo. E si può utilizzare allo stesso modo anche un videoingranditore da tavolo dove abbiamo un campo maggiore di visione rispetto a quello portatile. I portatili invece si può portare appunto in giro. E da non dimenticare anche la possibilità con i telefoni cellulari di utilizzare tutte la sintesi vocale e anche l'ingrandimento dei testi. Abbiamo detto che Giulia presenta un'opacità prevalentemente centrale, però un'opacità bilaterale della cornea. E ha un'acuità visiva di 1/20 con lettura di poche lettere nella prima riga a 2 metri. Questo è l'aspetto appunto della sua cornea. Ora, cosa succede dilatando la pupilla? Che si ha un miglioramento dell'acuità visiva, da 1/20 a 1,2. Questo perché? Perché vengono a essere utilizzate le zone retiniche che non sono alterate nella sindrome E.E.C, che non è una malattia rara della retina ma della cornea, e quindi andiamo a utilizzare la cornea media periferica che non è interessata dall'opacità, che è più chiara di quella centrale. E la visione quindi è migliore, ma certo non si può fare in modo di dilatare continuamente la pupilla perché ha una certa tossicità. Speriamo quindi che nel futuro si arrivi presto a individuazione delle terapie per queste malattie rare, in particolare nella sindrome E.E.C, in modo da tendere, diciamo così, l'arco della speranza, a scoccare una freccia dritto nel cuore della ricerca, perché gli occhi possono vedere tutto quello che ancora non hanno visto, ma che hanno la potenzialità di poterlo fare. Grazie.
I am Corina Costa, part of P63 E.E.C Syndrome International staff, and I will read Dr. slides in English. Let me share the slides. There we are. We're going to talk about visual recovery in severe vision impairment. I am Dr. Giovanni Sato, head at the Center Specialized in Vision Rehabilitation of Low Vision Patients at the Veneto region, within the University of Padova Hospital, which is part of the São Paulo Eye Center, directed by Dr. Alessandro Galan. Low vision refers to a visual impairment caused by a variety of ocular and neuro-ophthalmological diseases. A visually impaired person has an unsatisfactory level of visual ability to perform daily activities, such as work and leisure, if compared to individuals of the same age. Causes of low vision are different. Retinal or optic nerve diseases, which determine a decreased ability in the central and/or peripheral vision. Central and peripheral inherited retinitis disorders, which are rare diseases such as glaucoma or diabetic retinopathy. Opticopathies, such as optic nerve diseases, and neuro-ophthalmology diseases, as ictus consequences or brain cancer. Age-related and neovascular macular degeneration, and myopic macular degeneration, which are the most frequent cause in the Western world. Retinal diseases that affects the center of the retina or macula, a small area of a few millimeters located at the center of the retina, cause a central scotoma, which covers the reading visual field and makes the distant vision impossible. Diseases of the dioptric media, such as corneal disease with widespread central and peripheral cloudiness, are a result that give birth to a serious low vision problem. As a result, the low vision patient shows a visual impairment, and daily activities such as reading, facial identification, watching television, going to theater or cinema, studying, working, or leisure activities become impossible for him and for her. Huge problems in personal orienteering, since the patient find enormous problems in independently move in the city. And then, as we have already said, daily life activities and sport will be affected by this disease. The low vision person is potentially able to make use of the visual residue for the programming and execution of a particular task. Following an appropriate functional assessment, a visual rehabilitation project is drawn up in a way to consider the scale of the visual functional residue, the needs as well as the requirements of the visually impaired patient, and above all, his motivation to achieve these goals. And the macropathy, as you can see in this case, macropathy due to aging, the area used are eccentric to the central retinal lesion in order to be transformed in the macro area or preferred retinis locus. There are peripheric forms of low vision where we try to enlarge the vision field, particularly through the use of prisms, and then through a series of neurovision rehabilitation, such as transcranial electric stimulation associated to neurovisive stimulus. The low vision person presents different degrees of depression because there is a general lack of interest from society about his or her issues, problems, and disease. Society tends to isolate the individual affected by any disability because normally the visually handicapped person often finds the streets blocked off, and streets in this case is both in literally and metaphoric sense. The patient could think, if I ask someone to read what is written, that person will make fun of me and will ask him herself how this cannot be read. So he will be ashamed of interacting with others. Patients with hereditary maculopathies have to change jobs. For example, from tailor to nurse, from pharmacist to webmaster, because they have to do jobs with a less precision. And they have to give up sport, as we already said. Very frequent episodes happen when they cannot read a bus number, or when they cannot read newspapers, which don't bother to make the writing smaller and smaller. And all this leads to a state of deep depression and distrust in life and in others. The low vision person, as it should be for any other aspect of medicine, must be taken in care throughout an holistic treatment that sees behind the sick eye. A person with all the difficulties he or she carries within, with all their broken dreams, with a future entirely to be rebuilt. So this is why we should light a hoping light, because they have a huge potential and we have to help them finding and discovering it. We should guide the patient step by step towards a rehabilitation path that varies according to the disease, that causes low vision using specific perceptive cognitive training and instructions. We are gonna talk about Julia's example, who is affected by E.E.C syndrome, which creates a bilateral cornea opacity with a serious low vision. The retina is normal. However, the cornea is opaque. There is no chance with stem cells to modify this cornea opacity and return transparency to the cornea. Her ability to see is 1 on 20, under 1 on 10, so she sees through a fog. She's not able to recognize things or persons if not at a close distance. After a whole rehabilitation process, we have identified specific tools which permit to improve her visual abilities. When she uses telescopic tools, as in this case a Galilean one on the left and a Keplerian one on the right, by standing still, she can identify a faraway object to observe, which could be everything, for instance, a television. Then we have used enlargement softwares. These are important so the patient is able to enlarge as she wishes text and images on the screen. For example, this can be done with a mobile video enlarger. We can see here how she inverts polarity with this auxiliary tool, so she sees white text on a black layout, since she is also affected by remarkable glare, another characteristic of low vision patients. So by inverting the colors and enlarging the text, the patient is enabled to read. For a better reading capacity, we can use a fixed video enlarger, which presents a bigger vision field in respect to the mobile one. Moreover, we should not forget that there is also the chance to use mobile phone's option of enlarging text. So, Julia's disease affects the cornea, as we have already said, which presents a predominantly central opacity. Her capacity is 1 on 20, with reading a few letters of the first line at a 2-meter distance. And this is how her cornea looks like. With pupil dilation, something extraordinary happens. We observe an improvement of visual acuity from 1 on 20 to 1/2 on 10, with 35 letters reading instead of 5 with 1 on 20. This happens because we will use the middle peripheral cornea, which is clearer than the central one. The improved vision is also made possible by the fact that Julia's retina is normal. So in conclusion, what we are left with is an intensive investment in research. We hope that future will reserve scientific research great results for finding cures for E.E.C. diseases, so the eyes can see what they haven't seen yet, but have the potential to do. Thank you.
It's so funny, not only doctors in our staff, but also quick transformers. Dottoressa Roberta Bresciani, that was by my side as a speaker, now here to present you the Orphan drugs, connected by the studio next doors. Thank you, Roberta, our quick change pharmacist.
Good afternoon, everyone. I'm Roberta Bresciani, and today I will talk about orphan drugs and clinical trials. Before we go into detail, let's try to understand what a drug is. By drug or medicine, we mean any substance or combination of substances having curative or preventive properties of a human disease. Any substance or combination of substances that can be used in human beings for purpose of recovering, correcting, or modifying physiological function with a pharmacological action. All medicines are composed of active ingredients and various excipients. The active ingredient is the component of medicine on which its curative action depends. Excipients, on the other hand, are inactive components of medicinal products which have no pharmacological action. The other function is to protect the active ingredient from external agents that could damage it, like heat, cold, humidity, or other chemical substances to make a stable solution. But what is an orphan drug? Orphan drugs are used to treat diseases that are so rare that pharmaceutical companies cannot generate profits to recover the cost involved in their development. The process from discovery of a new molecule to its marketing is so long, 10 years on average, expensive, several tens of millions of euros, and very uncertain. Among 10 molecules tested, only one may have a therapeutic effect. Developing a drug intended to treat rare disease does not allow the recovery of capital invested for its research. Orphan drug may be defined as drugs that are not developed by pharmaceutical industry for economic reasons, but which respond to a public health need. Actually, the indications of a drug may also be considered as orphan, since a substance may be used in the treatment of a frequent disease but may not have been developed for another more rare indication. Orphan drugs can be defined as such in 3 cases. 1. Products intended to treat rare disease. These products are developed to treat patients suffering from very serious disease for which no treatment, or at least a satisfactory one, has so far been available. This disease affects only a small proportion of the population, less than 1 person per 2,000 in Europe, most often at birth or in infancy. The number of rare diseases for which no treatment is currently available is estimated to be between 4,000 and 5,000 worldwide. The second, products removed from the market for economic or therapeutic reasons. For example, thalidomide was largely used as a hypnotic drug a few years ago and was then removed from the market when its high teratogenic risk, causing fetal malformation, was discovered. However, this drug has shown very interesting analgesic properties in diseases such as leprosy or lupus erythematosus. These are diseases for which no satisfactory treatment has been available. 3. They that have not been developed, or because they are the result of a research process that cannot be registered for patent, or because they concern important markets which, however, are not worthy of credit, such as third world countries. Patients suffering from rare disease must be informed about scientific and therapeutic progress. They have the same rights to care as any other patients. To stimulate research and development in orphan drugs, the authorities have introduced incentives for the health and biotechnology industries. It began as early as 1983 in the United States with the adoption of Orphan Drug Act, then in Japan and Australia in 1993 and 1997. In Europe has followed in 1999 the implementation of a common EU policy on orphan drug. And now we come to clinical trials. When it comes to orphan drugs, their production is often linked to clinical trials, as they are drugs that need to be tested because they don't exist on the market. A clinical trial is a medical study conducted to test the effect of a new or already existing drug, of a biological treatment or a medical device that may treat or cure a disease already identified. The main goal of clinical trials is to compare 2 or several groups of subjects by using 2 or several treatments in order to determine the efficacy of a drug or of a biological treatment. Clinical trials are carefully and ethically conducted in order to protect patients against unwanted adverse reaction and to allow collection and accurate analysis of the information concerning the disease. There are 4 main points to know when talking about clinical trials. The first is to ensure that the new treatment to be tested is safe and demonstrate its therapeutic efficacy in a given indication. The second, drugs are tested on a human only after preclinical tests carried out in vitro and experimental models, which is necessary condition for the study of pharmacology or the study of therapeutic effect and toxicology of the active ingredients. 3. Persons wishing to participate in a clinical trial must be well informed about the study, including the side effect and benefit that may result from the research. The physician responsible for the trial has the task of explaining the protocol, answering all questions, and obtain informed consent from the participants. 4. The patient may refuse to participate or abandon a clinical trials at any time, and this must not affect the relationship between the patient and the doctor. The two main purposes of a clinical trial are to determine the safety, tolerance, and efficacy of a drug. What does tolerability mean? Tolerability is the ability to exercise therapeutic effect without inducing undesirable effects, benefit-risk combination. When a drug is active, it is by definition potentially dangerous, and its improper use can induce relatively mild disorder like dizziness, nausea or dry mouth, or more serious accidents like heart disease, anemia, bleeding. A new drug is tested in humans only after toxicological and pharmacological studies have been carried out on laboratory animals. Is the drug effective? Efficacy is by definition the ability to achieve the proposed therapeutic objective. When a symptom disappears, it doesn't mean that the drug is effective. This improvement or recovery may be due to other causes, the natural course of disease, an underlying pathology, or another therapeutic effect or a placebo effect. Clinical trials usually consist of 4 phases, which we'll now see in the detail. Before reaching the phase, we have the preclinical studies phase. Once the guide molecule is discovered, we start with experimentation. The first series of tests is carried out in the laboratory and is called preclinical testing. The preclinical experimentation aims to define the activity profile of the drug, define the efficacy profile of the drug, and start considering its possible toxicity to the body, study the pharmacodynamics of the drug, and start studying the most suitable formulation for its administration. At the end of the preclinical phases, there are only a few molecules left that can pass to the clinical phase after authorization by the competent national body. Only one molecule in 10,000 is able to arrive at clinical development, and only one in 10 is able to pass all phases of clinical development and reach patient as a standard drug. Clinical trials for testing a new molecule are normally conducted in 3 phases, each involving a large number of people. When a molecule is already known in other therapeutic indications, phase 1 is not carried out. Phase 4 studies are the longest and start once the drug is on the market, post-marketing studies. It aims at determining the adverse reaction and pharmaceutical properties that would not have been found during the first 3 phases. Phase 1. The first phase studies evaluate the safety of a drug and its pharmacokinetics. For example, what happens to the drug in the human body: absorption, metabolism, elimination, and excretion. These studies are generally short and involve in a small number of healthy volunteers, people without any diagnosed disease who wish to participate in a clinical study. They are admitted to hospital during the study so they can be closely monitored. The aim is to determine the maximum dosage level of the drug tolerated and the side effects that occur as dosage level increase. Approximately 70% of experimental drugs exceed the initial phase of the trial. Phase 2. These studies last from some months to 2 years and are performed on a small homogeneous group of patients. They aim at studying the efficacy of the product and determine the smallest efficacious dosing level and the best posology for phase 3. Only 1/3 of experimental drugs successfully complete both phase 1 and phase 2 studies. Phase 3, they are comparative study conducted on several hundreds of patients. This comparison is based on randomization of the treatments. They are double-blind studies. The treatment that is being tested is compared either to a placebo or to a reference drug for the therapeutic indication study. This phase 3 study allows researchers to determine the tolerance and the efficacy of the product and therefore to assess the benefit-risk comparison of the drug. They are large-scale studies conducted most of the time during 1 or several years. Relying on the result obtained after phase 3, the pharmaceutical industry can submit an application for marketing approval to the relevant health authorities. 17 to 19% of drugs entering phase 3 will be candidates for a marketing approval application. The last phase, the fourth, allows researchers to have a better knowledge of the drug by comparing it with other products already on the market, assessing the long-term effect of the patient quality of life, determining the cost-effectiveness of the treatment compared to the others. These studies are in progress and allow the pharmaceutical industry to have arguments to review the marketing authorization every 5 years. Now, very important when we talk about scientific research is informed consent. Let's see together what it's about and what it's for. Before starting a clinical trial, the sponsor must obtain the informed consent of all participants. This principle aims to ensure that each participant is adequately informed so that they are free to choose whether or not to participate in the clinical trials. When persons give informed consent, they must at least have been informed. The objectives of the research and its methodology, how long the study is supposed to last, the expected benefit, possible risk and adverse reaction that may occur during the study even if discontinued before the end. The other treatment available, the right to refuse to participate or to leave the study at any time without causing harm to the participants. All information is provided orally and in a writing on a document given to the person giving consent. In addition, a doctor is present during each interview to answer all your questions. Therefore, informed consent is a very important part for the patient and for those who want to undertake clinical research. Any doubts must be resolved before signing the informed consent. When we take a part in a clinical trial, are many questions to ask your doctor, and it is recommended you that you have as much information about the clinical trials as possible before giving your informed consent. Some questions I recommend you ask are: what is the purpose of the study and what should it prove? Who is the sponsor? Will you be able to continue your current treatment? Will other people know that you are participating in the study? Can you have the results of the trial? In any case, each clinical trial is also subject to the supervision of a competent authorities such as Italy, the Italian Medicine Agency, or at European level, the European Medicine Agency, and require, before it's carried out, the clinical trial authorization. In Italy, this request is forward to the Ministry of Health in the case of drug already on the market, or to the Istituto Superiore di Sanità in the case of newly established drug. It must be also examined by ethics committee. Good. My presentation is at the end. I hope I have been clear and managed to deal with these difficult topics with brevity. I remain available via mail for your questions. Thank you for your listening and your attention.
Well, also the second session, as indeed, we are collecting all your questions that will be answered, as a reminding, on our Facebook pages in the coming days. A few minutes of break, but we meet again at 16:30 for the third webinar dedicated to plastic surgery, maxillofacial, and dentistry. See you later.